Hey guys, welcome back to another video. In today's video, we have a special guest with us. We're going to be talking about raising the standard of nursing globally, especially from a Jamaican or Caribbean perspective to the international stage. We have a special guest. Super excited to have her here, Miss Sherry Ann, a nurse like me, and you can find her on Instagram, YouTube, TikTok.
No, not
Not
TikTok.
yet, not yet. So, nurse extraordinaire in digital content creation. I was just speaking to her that I remember meeting her for the first time a couple years ago, at our former institution that we used to work, and she was the first nurse who introduced me to making digital content, and she was doing quite a number of that, and she still is. Welcome, Sherry.
Thank you for having me.
All right. So, just a little backstory. Sherry is a nurse like us. For those who are watching here, former international nurse, transition, and both of us are living in the United States. So, I remember we were on another platform on Facebook. I forgot what's the name of the group again?
Jamaican nurses.
Jamaica Nurses. And if you guys are
Mhm.
interested, you can go and follow that group, and we raised a discussion, and that was raised by Sherry in terms of raising the standard of nursing, like looking at some of the nursing procedures that we do back home that needs to be raised globally. And it was like an interesting discussion, something that I always talked about, and we're going to talk about it here. Not only nursing too, we're going to trend into also healthcare, looking at healthcare back home, comparing
Right.
it to the USA, and how can Jamaica or the Caribbean improves its healthcare. So we're going to start. I want you to do a little introduction so that people can know you.
Okay, so I am Sherry and I migrated from Jamaica to the US in 2018, December 2018. Quite an awkward time, like the 21st, 22nd, close to Christmas. But it was an almost seamless transition as it relates to the company I came with. They provided housing, we were accommodated well,
Hmm.
transported wherever we wanted to go. So that part of it wasn't as bad. When I just left the company, my thoughts were very different from they are right now. So I'm able to see and assess that whole situation more rationally. So
Yes.
it wasn't a bad transition at all. I have been here for 5 years, just over 5 years. I've experienced wonderful times, not so wonderful times, but I feel really blessed because even the down times that I've experienced, it pales in comparison to the down times that I've heard from other people. So I'm
Yes.
like, you know what? This could have been so much worse. Outside of nursing, I have two kids. I'm married. I enjoy reading. I'm rarely ever bored because I'm either gonna sleep or I'm gonna be reading something. So it's like you not being around, I'm not reading for it. I'm good. So that's my life outside of nursing. Well, a part of my life outside of nursing. I have many passions, fortunately or unfortunately for me. But one of them is nursing, discussing nursing and anything nursing related. Because even though there are other things I enjoy doing, nursing is my career. Um, there's a side of me that enjoys not just the job itself, but how things came to be and how we can improve nursing generally in
Right.
Jamaica and globally. So that's me in a nutshell.
Okay, very good. Very multi-talented. One question I like to piggyback off before we jump into anything is like, since your transition now working in the United States, why are you so passionate about like improving like the standard of nursing back home in Jamaica?
Two things. Jamaica is always going to be home.
Oh,
No matter where I go, no matter how long I've been here, been there, Jamaica is still gonna be home. My parents live in Jamaica.
true.
Apart from my immediate family and three cousins that migrated to the US, everyone else is back in Jamaica. So why wouldn't I want to, improve what's happening in Jamaica?
Yeah.
Because if I'm here and my parents get sick, God forbid, I have to contact the persons who are back in Jamaica and if things aren't working right there, things aren't going to
Mhm.
work right for them in their care. So that's the main thing. And apart from that, I've always wanted to experience nursing outside of Jamaica. That's one thing. And while I was in Jamaica, I was still craving. I was looking on the internet to see, things that other nurses were doing. I was always passionate about seeing. improving and, doing myself. So that's what keeps fueling that.
Yeah, that's good. Very good. Many persons when they transition, they said, "Oh, I left and don't care about where I'm from. I'm good. I'm
Mm.
thriving." So it's very good to see when we have young persons still interested to create more development for the country back home, and that's how the country will progress also. So one thing I want to jump into is that we're going to be talking about raising the standard of nursing in Jamaica globally, and also once you're raising the standard of nursing, eventually it's going to trickle over into healthcare, raising healthcare globally, and it then begs the question to ask, when we work in other countries and you look back in Jamaica, do we have quality healthcare? you know, that's something that we can that's something that we can also look at. So I remember the first thing that we spoke about that you mentioned, and that's something that happened when I transitioned, like the very simple, it was just a lot of persons, like when I know, for I can speak for myself, like when I transitioned, one skill that I realized that I didn't have much experience in, even though we were taught it at nursing school, was venipuncture, sighting
Mhm.
and IV access. And I realized that once you transition, like think from many first world countries, like sighting and IV access is like a common skill regularly done for
Standard.
nurses overseas. But when you look back in Jamaica, we're limited and we're not allowed to do it in some institutions, as we saw online. What is your stance on that?
We should absolutely be practicing that skill. That's like basic entry level nursing skill that we should be doing.
Mhm.
I know that in Jamaica there was a tug of war. I can't speak so strongly about what happens now because I'm not on the grounds.
Mhm.
I've been a little bit away from, that kind of interaction. But when I was in Jamaica 5 years ago, there was a huge tug of war going on between responsibilities of the MD versus responsibilities of the nurses, and IV access. Citing an IV was one of them.
Mhm.
It's like there's a sense of dominance, control, that comes with allowing nurses to cite their IV. You're going to be a more independent practitioner. And I'm not sure why they're somewhere, they seem to be scared of allowing nurses to, practice that skill or own that skill. But it's a basic skill. Globally, you are expected to know how to start your IVs. And it's particularly embarrassing when someone asks you, how long have you been a nurse?
Yes.
And you're like, okay, I've been a nurse for 10 years. Okay, then you get the side eye because you've been a
Mhm.
nurse for 10 years and you don't know how to cite an IV. Then you have to go into this whole discussion about, okay, so I wasn't really allowed to do it. And if I was an A&E nurse in Jamaica, so we got some practice. But the
Mhm.
extent, I practiced in a small hospital, Portmore Hospital. So it's a small facility. So more often, most of the times, there was a doctor available to do your
Mhm.
IVs. So it's like you were taught it, never got a chance to practice, so you just lose the skill. So I had
Right.
to start over when I got here, basically.
Right. So, in terms of that, we might also, when the discussion was raised to quite a number of persons, lamented that you do have nurses back home who can cite the IV access, but they were in more like a public setting, like the Spanish Town and the KPH, But for though I don't know if it's still there, but there are policies implemented, especially in the private institutions in Upper St. Andrew, stating that, you're not allowed to cite these IV accesses. And I believe in it. I don't know if you believe to that. This should be something that is cut across the board because it's like a common skill. And we
Absolutely.
do see, like for my transition, I do see where it's necessary and it delays care when you have a nurse that is waiting on a doctor to come and cite an IV access. And the doctor is tied up with so many other stuff. And to me, it's like you're putting like just as you say, a tug of war, allowing nurses to do nursing skills and allowing the doctors to
Mhm.
do their medical skill. Not to say that it's like it's only for nurses, but it's for everybody. But we actually see where it delays care in terms of that. So, my question to you: what improvement will it do to the system if they implement something such as this to make it cut across the board that IV access should be cited for nurses?
First of all, as you mentioned, it will prevent incidences where we have delayed care.
Mm-hmm.
A doctor isn't always available at the bedside. If I'm serving antibiotics, like in the US, in the ED, you have a 1 hour window from when the IV antibiotic is ordered to when it is
Mm-hmm.
given. In Jamaica, there was no such standard, for example. You just give
Mm-hmm.
it when you can give it. But
Mm-hmm.
imagine being on a medical floor. You have no IV skills. Patient is getting antibiotic 3 times per day. Misses 6 o'clock dose because the doctor was caught up with another patient, an emergency patient who needed them more than this patient for the IV. Miss a 6 a.m. dose, miss dose. Okay, so you go on to maybe give it later that morning, or they miss the entire dose altogether and it's 2 p.m. dose. That is the dose, not just delaying the initial care, but it's delaying the entire recovery of the patient. And also, for me, how you feel about things is very important. As a nurse, I want to be able to practice to the fullest extent of my scope. As an individual, Maslow talks about self actualization. You want to do as much as you can.
Mm-hmm.
And it's a skill that you can learn. It's not complicated. If you do it often enough, you get it. You
Mm-hmm.
get to master it. So I think that for the individual just to feel a little bit more independent and for ensuring that patient care is not delayed. Those are the two main reasons why I think we should be able to do it without any complication. And nurses citing IV accesses does not take anything away from the physicians. It
Mm-hmm.
doesn't. It just helps us to work together better as a group. And of course, there were nurses who sometimes befriended physicians or some physicians who realize that this rule isn't really working at our facility. And they would encourage and assist nurses to learn the skill and they
Yeah.
practiced. And that's absolutely commendable. But citing an IV shouldn't be something you have to negotiate with a doctor or get on their good side in order
Right.
to learn how to do. It should be an expectation and we should be taught how to do it coming out of nursing school.
Nursing school, because in nursing school you're taught how to do it. So for me, I think it depends on the area too, because I know when you become specialized in the, that's another big one too, that when you become specialized, say for instance you went to A&E or you went to ICU or midwifery, that's where you start citing IV accesses. But when you
Mhm.
look at the nurses who work when during my time back home on the medical and surgical units, these are one of the most, what you call it now, what you then say, high ratio units, very heavy. These areas should allow their nurses to be able to cite IV accesses. And my thing is that for the regular persons that are watching and not be nurses, I don't want people to move away from this to say that in terms where we mean delayed care, that the doctors are probably sitting down and taking their
Mm-mm.
own time.
They're
They are
genuinely
tied
busy
up, short
sometimes.
staff, have so many other things to do, and may be dealing with more critical cases, and you still have to sit and wait for them, and it delays care in that frame of work. And I know we want to raise the standard of nursing globally, and I think for those who are sitting at the tables, the decision makers,
Mhm.
when you do allow these skills to be given to nurses, this is where you can see more improvement in patient care, improvement in quality, and all of that. And these are some simple experiences that we have seen working in the US. So, and when we look back home and say, boy, I wish we had this back home, because
I wish, and it doesn't
no,
require anything extra. You already
nothing.
have the same persons who are working in the department. Just teach
Hmm.
them the skill. You don't
Right.
have to do it like there's no set thing where you have to do like a 2 week conference, a 2 week skills, whatever it is, on the job. And this is where I learned in the US how to appreciate on the job training because in
Training,
Jamaica, everything needs to be formalized. Coming from the
school.
British system, everything needs to be formalized in order to be recognized. But I'm like,
Mhm.
there's so much value in on the job training. As long as
Right.
you're taught how to do it properly, you're signed off that, hey, this person can perform this skill, do it enough times, and you're good. That's one thing
Mhm.
I really enjoy. And I
Yeah.
wish Jamaica would adapt as well.
Just another area that I thought of when speaking of the IV access is the level of autonomy that the nurses have.
Mhm.
We still work along with the doctors, but I think back home, you have to wait a lot, for doctors' orders. You have to, anything that you do, you have to seek some form of what you say,
Some validation or
validation from
from
the
the
doctors. Like, that was a culture shock for me when I came here, that it is so. And I think, I've heard persons stated this already. I'm not bashing the system. I love my country. That they felt that they, when they transitioned, that they were doing more of nursing care. I never know if you heard it before.
Mm.
Pers-
I'll tell you my experience. Let's finish that thought.
you can go ahead.
I don't necessarily think I'm doing more of nursing care per se.
Mm-hmm.
I'm doing more tasks.
Mm-hmm.
It's more task driven. I always say in Jamaica, I spend more time with my patient.
Mm-hmm.
There was nobody clocking me on like, okay, so you need to do this, you need this, the time frame. And sometimes these things, these parameters are good to have. For example, giving my antibiotic within 1 hour of it being ordered.
Mm-hmm.
If I don't, pharmacy is going to report that dose. Say, hey, this was given outside the window. You know, patient will still get it, but they want it to be given within a set time. You know,
Mm-hmm.
that's a good thing. So they're watching you. Everything is on the clock, on the computer, everything. But in Jamaica, I was able to spend more time at the bedside,
Mm-hmm.
um, caring, talking to the patient. You know, if somebody comes in, you're going to hear about, we like to ask about the 15th generation, you know, up to the 15th generation. You're
Yeah.
going to hear about the son, the grandson, everything. So
Mm-hmm.
it was a more therapeutic atmosphere
Mm-hmm.
as it relates to allowing patients to express themselves in a relaxed manner. Here, I have to do an abbreviated version of that. It's hi, how are you? Introduce myself, tell them what I'm here to do. Do you have any
Fact, fact.
questions?
Yes.
And I'm in and out, you know. So
Mm-hmm.
it's less time. So I don't necessarily think that I do more care here. It's more, I have more things to do, more things on my to-do list. But I feel as if there's a part of nursing in Jamaica that we still have to embrace,
Mm-hmm.
that slower pace and your
Yes.
ability to have a more intimate relationship with the patient, know more about them, not as individuals really, well, not only as individuals, but to know about their illness, the history of their illness, and all of that. So I really do appreciate that part of it.
Yes. As to piggyback off of autonomy, I was impressed in the level of autonomy that the doctors actually have with the nurses. Like, you have to know everything to the T. And when they come to you, and they ask you, tell me such and such, they're taking everything that you say, and then just step into the patient's room. And I was so impressed with that.
That was a
And
big
it's the
deal.
lead, and it's not like the junior doctor, the head
Mhm.
doctor, the lead is acknowledging your presence and say, hey, tell me such and such. And they're looking to you as a point of reference. I'm not saying it doesn't happen in Jamaica, but I can speak from my experience. A lot of time, I can speak from my experience. There are doctors back home do acknowledge you, but that level of autonomy is not really the. I didn't experience much of that autonomy. I
Mhm.
know sometimes you'll have consultants. Sometimes they probably walk past. Yeah, some
You have to
instances.
prove yourself in
Yes,
Jamaica, like that
yes.
level of I'm gonna call it professional camaraderie and
Mm-hmm.
trust that is almost expected of you here. Not necessarily not friendship, but you know we were working together. Hey, tell me about the patient. The expectation is that you know about your patient,
Mm-hmm.
and your contribution is valid to the conversation. In Jamaica, you'll get that most often when you've worked in an area for a while. The provider, the doctor knows you, trusts your opinion. That's when you get
Right.
that level of trust to say, hey, tell me about this, tell me about that. When I was here, my first time interacting with a doctor, I was so surprised because I told him the problem with the patient,
Mm-hmm.
and he was like, okay, so what do you want me to do?
Yes, I had that
Um,
too.
I was for a few seconds, I was like, okay, does he really want me to tell him what I think, or is he just being
Mm-hmm.
rude? And I found out that his tone wasn't really off, but
Mm-mm.
coming from my cultural background, nobody really asks you, so what do you want me to do?
No, they
Nobody's
don't.
asking you that really.
Mhm.
So I was very taken aback. But I realized that that's the expectation. They don't
Right.
just want you to tell them what's the problem. You say, hey, this is a problem. This is what we did before. This is what I've done so far. Do you want to? They want you to, the expectation is that you're going to suggest the next step. Would you
Yes.
like to do this or that or that? And I
Mm-hmm.
find that very refreshing. I enjoy
Yes.
that.
Yes.
Hmm.
And I can share an experience with you where I would call the doctor and told him the problem. And I went ahead and did further assessment. And I said to him, you may want to order this. And he put it in. And
Hmm.
and by the time he came to the unit, they came, did the procedure. He got back the results. And I told him some other stuff that was happening. And he was like, let's do a transfer. And you saw the level of autonomy, the communication, and how quick the care was, based on
Mhm.
what was happening. And that's something that I admired a lot.
And that doesn't mean that somebody who is shy or more reserved should
Hmm.
feel as if migrating to a new, a new country is intimidating. You learn
Right.
as you go. I had to adapt. It's not that in Jamaica I had nothing to say. It's that many of the physicians wasn't really interested in what you had to say about the next step. So I'm like, I'm not accustomed to sharing my thoughts with you,
Hmm.
but I had thoughts and many of
Yes.
them.
Yes.
So it's if you're shy or reserved, you get to grow into it. Just make sure that you know what you're about with your patient. And guess what? If you don't know, you're not the only person on that unit.
Right.
Ask somebody else who is more experienced in your area, who is senior to you. Your charge
Mhm.
nurse is always a good resource person to, pull ideas from. So
Right.
yeah.
Something else that I remember that we spoke about, and I talked about the level of autonomy too, and you know, not just when you have your patient care and just watching your lab values, especially on the medical and surgical
Labs.
units. That was a culture shock for me too. You have to
Mm-hmm.
pay attention to those, and then sometimes
Yep.
depending on the shift that you work, you call it out and say, "Hey, this is happening. We need to order this." So just going back to that level of autonomy, and it does help, working together. We're not saying it doesn't work home, but there are some instances where we can grow with regards to that. And
Mm-hmm.
when we mentioned another aspect is when we do insertion of Foley catheters, that
Oh
that's
yeah.
that's
Mm-hmm.
limited back home. I don't it is that the males that we are not
Male
allowed.
categorizations. Mm-hmm.
Right, we're
There
not
is
allowed.
no reason why in this day and age, and this is not a new thought I developed
Hmm.
since moving to the US. This is something that I've spoken about while I was in Jamaica. As I said, I did the A&E course, so we were taught how to do the male catheterizations. We had to participate and observe quite a few. I think I did my observations at UWI at
Hmm.
the Catholic clinic, right? So we were taught how to do it. There's no reason why a physician should be held up to
Right.
do catheter clinic, and you have nurses who are capable, able, and available, to do those procedures. And I only was allowed to do that because I did the A&E course, but I didn't have any superior skills that another nurse who isn't A&E trained couldn't be taught how to do the same procedure. So it's like some things are just what I call it, some procedure that is guarded,
Yeah.
um, not just nurse to physician, but even within nursing. Because why couldn't I teach another nurse how to do that procedure? Okay, they say, okay, so there's likely to be damage to the prostate. And if I am doing a Foley as experienced as I am, and I meet resistance, and I pull another colleague and say, hey, come and try this Foley for me, and they meet resistance, you're ultimately going to do the same thing. Go to the
Mhm.
provider, say, hey,
Right.
this is the problem. So if
Mhm.
I teach my colleague how to do it and they meet resistance, and they call me to help and there's an issue, we're gonna do this. The outcome is the same because nobody wants to put their license in trouble as
Mhm.
nurses. So you're gonna do your procedure as you're taught, but you're also gonna be cautious while you're
Yes.
doing your procedure. So some things just need to be. I think at this point they have a list of procedures. The nursing council needs to, not the nursing council, the NHA needs to
Yeah.
do more advocacy for nurses and in terms of autonomy. Have
Right.
a list of procedure that can be taught on the job, list of 10 procedures per se, and discuss how this teaching will occur, and
Mhm.
put that to the nursing council because they're ultimately the ones who draft the legislation and say, hey, this is your scope of practice and all of that. So they're the ones who has the power to make those changes. But without recommendation, we're gonna sit and we're gonna have these discussions and we're gonna feel really emotional, passionate about some things, and nothing is going to change. So we have some ways to go, but this is
Not
a
we have a
start.
this is a start, and I think we have a long way to go. Because imagine, I know you said, but if you were in A and E, you weren't able to cite. You were able to pass the Foley catheter for
The
males.
Foley, we did it, but we weren't able to do, we weren't allowed to do like a catheter clinic. But
Mm-hmm.
if a patient came with acute retention and there wasn't a physician readily available, you could relieve them.
Okay.
So it
But
was
I
to that
know
extent. But
I remember, I don't know if it has changed, but for back home medical surgical floors, that the nurses had to wait on like a urologist to come and do that insertion. So can you imagine that wait time? And especially if that urologist is consultant and have clinic day, that wait, and if the intern is tied up. And that was a culture shock for me when I came here. If you tell me to pass a Foley for a female,
yeah.
quickly. I
Mm-mm.
was so scared to do the one for the meals because guess what? I didn't get the opportunity back home to do it. It was like a red tape. This
Mm-hmm.
person had a consultant or urologist had to come and do it. And when we started practicing it, I realized that it was super easy. As you said, if you're doing it and you meet resistance, you stop,
Yeah.
ask for help.
Mm-hmm.
And this is how the care improves, and then you have more, nurses have the ability to get the care done, and it improves the service, and you can have more quicker times in care being done. So as you said, having a list of the skills, and also stop having this heap of red tape that you can and cannot do. To
Mm-hmm.
me, sometimes you're just holding back our persons, but then persons will be saying that you want to give us more work. That's another question.
Um, it's twofold.
Hmm.
More work. We are more efficient. Sometimes the frustration of waiting for something to be done psychologically stresses you out more
Right.
than just doing it yourself. Imagine the scenario is you're on a unit, you have no patient care assistant. You know that if something comes up, you're gonna do it to get it done. That's done. That's better for you than to have one. They're not doing what they're supposed to be doing. You have to micromanage them to get the same thing done.
Mm-hmm.
That's more frustration. For me, some things, as if I compare my experience in Jamaica and the US, Jamaican hospitals didn't have the capacity to make me work as hard as I work now. I've never worked this hard as a nurse. I tell you, the list is long and the clock is ticking,
Yeah, we
right?
didn't have. I can say too. They didn't have the capacity. Would you say they didn't have the capacity because they didn't have the resources?
Yes. How
Yes.
are you going to make me do all these things if you don't have the
Hmm.
equipment to make me do it? So some things are just null and void. So expanding our scope to allow us to do simple things like siting IVs, doing the catheters, it's something to do to improve your skill set as a nurse. And
Hmm.
many persons want to be, global.
Right.
So that's an expectation. So why not just work on it so when you come here competent?
Yes. I'm making the nurses like more marketable. We are marketable across, but giving us like that global appreciation. Do you have any other skills that you think that there needs to be more allowance for nurses? Or I'm going to touch on resources, and one big one I have coming up, but I want you to give us some more if you have any more.
Not necessarily resources, not necessarily skills, but that issue of autonomy.
Mm-hmm.
Patient comes in, you are the first person you're working. My reference point is the emergency room because that's where I've spent all my time in nursing except for like 1.5 year. So the patient comes in. My current experience, the patient it's some time before the patient actually sees the physician. So everything in between. For example, your coming blood pressure is high. I'm asking you what medications do you take for high blood pressure. I'm sending that information to the physician. Hey, this person takes this. They miss their even dose. The blood pressure is this. What can we do while the person is in the waiting room? I can take a verbal order, or the physician puts the order in. And in some facilities, there are protocols that you can follow. So the patient is already on this, you're allowed to do this. So it's a greater level of autonomy. And I think the emergency rooms in Jamaica could benefit so much. The patient needs some Tylenol. They're waiting for the physician for 4 hours
Mm-hmm.
to get that Tylenol. We could relieve the pain, relieve the frustration as well while they wait to be seen. So it's simple things, simple steps. You're not how should I say this? You're not diagnosing anybody by any means, and you are not ordering medications. But if we had protocols in place, for certain things. It would make life so much easier. First of all, it would cut down on the disturbance. The nurse is disturbing the physicians so often in the emergency room for what they deem as simple things that could wait. No, but if you can relieve pain, relieve fever, you know, do some additional things while the patient's wait. Sometimes it's not Tylenol, but something stronger than Tylenol. I'm not ordering anything, but if you give me a verbal order, and I could medicate the patient while they wait, that would help so much within our local healthcare system.
Right. So true. We did touch on those, and I think that would be a recommendation that you have to give to persons such as the NEG to advocate for more autonomy for the
Hmm.
nurses, and giving them more, getting them more, what you said, more skills to be done,
More
and
space to
prevent
practice.
and to improve the nursing practice, to putting us on a global stage. But when you're doing that, there has to be resources that are available. So we're heading now in, to healthcare. And you did mention a while ago that you never worked so hard as that you did
Never.
here, and I can say the same
Mm-mm.
thing. Same thing too. Back home there wasn't the capacity, but there is the lack of resources. And in this day and age, I think that we should have moved, slowly gaining momentum to get resources on our units back home in Jamaica. When you talk about resources back home, everybody talk about common things like no CT machine not working, all of those stuff. But as coming back to nursing, one of the biggest things for me when I came here was the lack of use of telemonitors, especially on our medical and surgical floors for every
Mm-hmm.
single patient. And it burns my heart so much, when you come here and you see it and you're not seeing it even on a regular unit, back home. And the telemonitors are like your cardiac monitors for your heart patients and all that. For monitoring their heart rate and everything, and can tell the rhythm a patient is in. And I worked back home on a medical floor for 5 years, and we did not have access to that. What is your take?
Right alongside the telemonitor is the IV pumps.
Right.
Did you have IV pumps that you use on a regular
Scarce.
basis?
We did have the
I know that
BB.
you is a little bit bougie. They have more resources,
Yes.
but in the public sector, never touch an IV pump. That's such a no. When I look at it, I'm like, we were just practicing so recklessly. Not of our own design, but just lack of access. How do you do heparin without the IV pump?
Yes.
Okay, you can argue, oh, drip calculation, really?
Hmm.
How accurate is that going to be? When the
Right.
patient bend their arm and the patient didn't get the last 50 mils that they were supposed to get over time, how do you assess that? How do you know how much a
Hmm.
patient has gotten so far? Those bags are not accurate. We all know that.
Hmm.
Estimating from the bags is just an estimate.
Listening.
There are so many medications that we should have been given via IV pumps
Hmm.
for the patient safety that we weren't able to give. What we used to compensate for that though was the pediatric. I don't remember what it is called. I hardly work with kids now. That
Me, I've
little,
never.
oh my goodness, I don't remember the name of it, but you cannot
Is
the
it the
IV bag.
Buretron?
Yes, that's
Yes.
it.
Hmm.
Yes. So for those more sensitive drugs, we would use that. But even then, the IV pump is gonna alarm when the arm is kinked, if it's in that area. So you know when something stops and you know when to stop it and all that. Monitoring of glucose resources. Patient is in DKA. Who monitors the patient every hour on a regular medical floor in Jamaica? Check their glucose and know how much insulin to administer every hour.
Hmm.
I had a situation where pharmacy let us know that we cannot afford that. Because you'll be going through the strips like nothing. We didn't have the resources. So
Yes.
I work harder here and no, because
Mm.
they have the things to make me work harder. And it's
Yes.
a requirement now. So it's different. Even
Hmm.
labs, like certain facilities, you're not going to get your labs back quick enough to
Hmm.
make changes to the patient care in a reasonable time. And it's so sad.
It
You know,
is.
it's more work for us now because we're required to do it. But when you reflect on what's being practiced back home, you're like, these things shouldn't even be like this.
Yes.
So
It
it's tough.
It is tough and it pains my heart, when you come in, you can see it and then you have your family and friends back home. And I think not only my family and friends, but the people of your country like deserve more. And like the
Mhm,
persons who are sitting at the heads, these are the necessary implementations that they need to
mhm,
put in. I know telemonitors maybe be a bit of a stretch, but for me, it should be a basic commodity. And I did have this discussion with somebody back home, a consultant back home in Jamaica before I left, and he complained about it too. And he said, how can you be on a medical floor, internal conditions, and we don't have telemonitors?
mhm.
You can't see the rate the
The
patient is
rhythm
in, the
changes. You
rhythm
don't know what's
change,
going on with the patient. You don't know. You are nursing
nothing
blindly by faith. It's just by faith.
by
Also, things you just
faith.
wing it. Yeah.
And I can tell you, it is super sad. And not to mention defibrillators. I can tell you, I worked on floors where the defibrillator is not working. How can you have that?
And you know what I discovered when I came here? People might have known this before. Kudos to you. In the emergency room, we had one EKG machine, and the patients that were cardiac patients that were most ill. I didn't realize at the time that we could just connect them to the EKG machine, leave them connected basically, so that it's a kind of a makeshift thing, so
Mm-hmm,
we can see changes in the rhythm over time,
mm-hmm,
right? But guess what? You could say, oh, you could try that, but you need that for every 10th patient that comes through your emergency room door. That
mm-hmm.
same EKG machine. But had I known, I would have advocated for at least another EKG machine if we
Yeah.
weren't able to get a monitor so that the illest patient could have access to that.
Mm-hmm.
So it's like, if you don't know, you just don't know.
You
And
know,
know that you have more experience and exposure, and you look back, you're like, things, even with the limitations, some things can be better, but we just didn't know what we're missing out on, a few years ago.
yes. As you said, when you look back, you said it is reckless.
Yeah, really reckless.
Reckless. And as you mentioned, EKG monitor. I don't, when I was back home, we didn't even have one of that on our floors.
But
Medical.
emergency room had that for sure. Yeah.
Yeah, emergency room had that, but
Yeah.
where emergency room gets the patients, and where do most of the patients stay? On the medical and
Right.
surgical floor. So
Mm-hmm.
those stuff are needed, and that's where advocacy starts. But I think it's, unless, I don't know, I don't even know what to say, unless persons step outside and see, what the world standard is, then persons will actually wake up and say, realize that this is what is needed.
I have to say kudos though for my short time at UA.
Mm-hmm,
Sometimes it feels as if it didn't even happen. It was so short, like a few
mm-hmm,
months. I must say that emergency room had so many opportunities for nurses to have greater autonomy than I'd ever experienced working in the public sector. They were able to do so much more. I didn't stay there long enough to really immerse myself in all of it.
mm-hmm,
Because psychologically too, I knew that I'm not gonna be like, he's like, I'm here for a good time, not a long time kind of thing. And I mean that in the most respectful way because I know they're very sensitive. I knew I wasn't gonna be there long. So I didn't immerse myself in some things. But that's the first time I experienced that level of autonomy with nurses.
mm-hmm.
Getting things done with the patient, come you get the history, you start the IV, you take the do the labs and all of that. That was my first time experiencing that, and I'm really grateful for that brief introduction because it helped to set the stage in terms of the expectation for what was
Mm-hmm.
to come at the time.
Yeah. And even though we may speak about it, a lot of persons say you can't compare, but this is where we have our experience in.
Mhm.
Despite all of that, we're one of the most sought after countries in the world. Then and also other countries on the Eastern Hemisphere in terms of nursing, and that speaks volumes. Like with the doctors and the nurses that we're able to work without, and then
Mhm.
matriculate to other places, first world countries, and also do so well. And can you
Mhm.
imagine the impact that healthcare could be back home if we
Yes.
just had the resources?
Mhm.
A
And
lot of.
as I said,
Mhm.
go ahead.
You can go ahead.
It's not a lot in terms of course we need some money to create some of these things, but some of them it's just permission to do. It's not necessarily pushing a lot of funds, even though that's needed. Many things are just permission to just do and be. That's all we ask for many things.
Yeah, and resources, as you say, and the permission is needed. Advocacy is needed. Sometimes I wonder who are the persons that need to advocate. And I literally ask myself, is it that persons who are sitting at the head, like they don't know, they don't understand, or is it because the nurses who work at the lower end, they are the ones in it, experiencing it and feeling it, they're the ones who may speak up, but their voices may not be heard. Who are the persons that literally need to be pushing this, advocating for this and all of that? But
That's why
it's a
experience is outside Jamaica is relevant
mm,
to practice in terms of being a better nurse in Jamaica. It would be nice if you have experience outside of Jamaica in a first world country so you can know what we're missing. If you don't know what you're missing, you think you're doing great.
exactly.
One thing that really works in Jamaica is the people who work. We work. And I think that's one reason why we're in such high demand globally because of our work ethic. It's like when you finish caring for your patient, the patient is. I always take pride. The patient should be looking nice in the bed. The bed should be looking nice before they get in there while they're in there, and we take such great pride in our practice. But it's like if the persons in charge of steering nursing in Jamaica don't understand what we're missing, or if they know we're missing some things, but they don't have the motivation, the drive to push through and cut through the red tape and get it done, then it's stuck basically. But
Yeah.
I think we need to expand that conversation to find out who do we need to speak with, what do we need to do, you know, on the other side to encourage, because it's not just pushing things through the pipeline. If the nurses on the ground don't see the need to improve their practice, all these conversations, on and offline, it's like makes no sense because
Right.
the people who should be doing the work are not interested. So
Yeah.
that's the other point as well.
And I love the point that you raised with regards to that. If the nurses don't see the need to, that they're not going to push. It begs the question. This is another issue that I struggled with back home. And when I came here, it was vast research, journals.
Mm-hmm.
Every minute you're on social media, there are so many organizations pushing for abstracts from nurses. That's another era of education. And I always complain about it, even from back home, that we need more research that is centered around nursing care, persons who are advancing it. Probably it was there and I didn't see it, but that's something that I said can help to raise the standard. And something that I noted here is that they use a lot of clinical, they call it CPGs, clinical practice guidelines. If you're managing
Mm-hmm.
hypertension, you have a guideline, to follow,
Right.
and that helps to create something that is cut across the board, creating like standards. And I think for me, that was an experience that I saw that we're limited in research, pushing journal articles and advancing or nursing back home. And a lot of people may say that resources are our next thing, money is our next thing, which I think Jamaica receives so much aid, so much support, but it
Mm-hmm.
then begs the question, where does, the money eventually go to,
That's a whole other
you know?
conversation.
Yes, but it goes back to say that more advocacy is needed in terms of that, in just pushing forward, to elevate the standard of care, because we do have it, we do have the care and everything, but it needs to be on like a global perspective.
Mhm.
I know we talked earlier in terms of education, right, and more research, more journals. I know we do have journals, like I think it's a Caribbean medical. I think it's a Caribbean medical journal, but I have not. And there are research that is being pushing, but probably I may not see it. I may be ignorant to it.
I I just sit oh this part of it because I wasn't really in search of like locally done
Mm,
research papers because when we are in nursing school and we're searching for that kind of information, the information was so outdated that it didn't seem relevant. So
unlimited.
I kind of lost my way in terms of research
Mm,
while in Jamaica. Here, I know. I won't say that I'm never gonna be the nurse really doing the research. The whole research
mm,
process in nursing school was just it just seems so complicated. Not to learn the concept, but just getting approvals to get things done and going back and
mm,
forth. And, I'm like, okay, so this may not be for me, but I love to read research papers. So even doing assignments, it takes me longer than usual because I'm gonna read that thing. And if I find it interesting, it's worse. I'm gonna read it through and through. Forget about the assignment, I'm gonna read this paper. But research here seems to be so much more simplified. When you look at, because as you were talking about the policies, people do their whole research paper, just comparing the standards of practice at this facility with the outcomes of the patient at said facility. I'm like, oh, this is not so bad.
Mm-hmm.
And it's just so fascinating because I work at a teaching hospital. They do a lot of research and everything, evidence-based practice that's pushed so hard. It's like,
Yes.
okay, so a DNP student is doing a research now. Months later or a year later, they publish the results. You get to see the results. A year later, it's like, oh, we're gonna change how we do this and that because of that same research paper that was done. So it makes it seem more within reach to get things changed based on the current evidence, and it keeps everything current. I think that's what we're lacking to with
Yes.
information in Jamaica. Things are not current, so you don't know what's working really because it hasn't changed in such a long time. And I think we need to work on that because we have
Mm-hmm.
persons. I may not be the one, but I know there are persons who are passionate about research who will be willing to do the work and bring the findings to the public, and the hard part is getting it accepted and
Yes.
policies changed.
Mhm. As you mentioned, like persons doing the research, for me, I've had the experience working at the teaching hospitals, and every week there's a new update. We're going to stop doing this. We're going to be to the point I've been asking, is this written down, please? Because I need to see it written in black and white. And they
Mm-hmm.
do a lot of studies, even on your unit too. You see a simple study taking place, they read the
Mm-hmm.
results from that, and they say, hey, this is going to be submitted, and this is what we're going to be doing next because we're improving quality. And they have a lot of standards that they do in terms of that and the bundles and all that you have to follow. And I think that helps too with improving the career, pushing the standard of nursing also. And it gives them, more autonomy that we're speaking
That's the word I
about.
was going to say next. Yeah,
Mhm.
absolutely. So you can advocate for yourself because we've tried it. We know what works, and what's happening over here isn't what's working. So let's do things different. And that has nothing to do with other providers in healthcare. It's just a nursing thing,
Mhm.
nursing research. I think if we can start a little bit at a time. There was a research I read maybe a year ago of a nurse. The simple thing she was researching on is just well-being of nurses post-COVID.
Yeah.
Her audience wasn't very large. She did it at between, well, it was one healthcare system, but like within three facilities. So it's just limited to that. But it's like her research paper, I'm like, it's almost like I could have done this. When you read how she collected the data and all of that, and her, the participants and everything, it's not that deep. In terms of,
Mhm.
I'm not, dismissing her effort and everything, but I'm saying it's a she didn't make it complicated. It was a simple idea. She went out, collected the data specific to that, and she was able to publish her results. I'm like, wow. And this simple paper, it was like 3 pages, can affect change in how we practice,
Yeah.
So it's a matter of us knowing what to do and embracing the outcomes, and being willing to change as a result of the outcomes.
You know, yeah, and I love that point too. And another common complaint that everybody talks about is long waiting times at hospitals, lack of beds. And I can tell you, it's everywhere. It's not Jamaica alone. Every single
Mhm.
country across the world is suffering from that. There are so many different options that persons can use. And I see one thing that they over here that they use a lot is like telehealth, virtual
Mhm.
nursing, use of technology and all of that. And that really helps. But before we touch into that, I want to piggyback off education. Another red tape sometimes can be for a lot of persons. I see here where advanced practice nurses that we call they're called nurse practitioners come
Mhm.
on here very a lot of across the United States. And they are given so much autonomy, in different depending on the state that they're working. It's either work under a doctor to open private practices, and studies have been done where this has proven to help in decreasing the number of persons, that visit hospitals, because they have that aspect of primary care.
Mhm.
when I came here and I saw that I was working a lot with nurse practitioners, we didn't have that back home. Many of them are in the hospitals too. You can find them in the clinics, and many of them, operate similar. Very some of them operate so much as I think sometimes I'm dealing with an MD. How talented they are, and then when you look back home on the system, we don't really see much of them. It's not like a big thing back home, and they're mainly in clinics, and they're not given the authority to open private practices on their own. Many of them have to still be under the use of a doctor. What's your stance in that, in like opening up the system and making or allowing nurse practitioners to help to offset some of the long waiting times and delayed cares that hospitals back home are experiencing?
That's a big deal. That is gonna take much more time it's gonna take much more time to get there. Because first of all, if they didn't want you to even side IV, you think they're gonna want you to open your own practice? You think so? You're gonna have an MD in the because most of our doctors' offices are like in the town areas. You're gonna have an MD's office here, a nurse practitioner office here, and an MD office over there. You're in the middle. You're not gonna enjoy that, because traditionally nurses, many doctors are more, chill, low key at their private practice. But a skill that nurses tend to have is our ability to slow things down, listen to the patient, and and people enjoy when they know that they're being heard. They're being heard. So I think that's gonna create a lot of too much competition for comfort. Um, I'm not taking away from the experience of an enthusiasm of said nurse practitioner, but that's going to take a lot of work, a lot of advocacy, to get there. So I think those who are already practicing should set the standard to practice at their highest,
Mm-hmm.
improve their game, and make the profession, I think, of being a nurse practitioner seem more attractive, and encourage that level of autonomy. Well, work as much as they can within their scope at the highest level, and advocate too for expansion of what they can do as nurse practitioners. But it's
Right.
going to take a lot of time.
It is, and I think I've heard persons state that they have been pushing back home to advance their autonomy, but they keep it's always like a pushback. It's not being given that autonomy, and I
I
don't
tell you,
think,
it's a tug of war.
yeah, it's a tug of war, and I don't think persons in the system understand, how they do help and how first world countries are utilizing them, especially when it comes down to rural care,
Mhm.
because many of them can be found in rural areas, assisting the patients, preventing them from going to the hospitals and dealing with that care and decreasing the number of hospital beds that are occupied when we have the nurse practitioners. And I think that's another area that they can look on, because that's an area they're struggling a lot, and a lot of
Mhm.
people complain about the long waiting times, and not to mention education. I know back home, I don't know if the system has changed as yet. The requirement was that you needed to have 5 years experience before you could become a nurse practitioner. And I'm
And
like,
getting there,
and
how
getting
do you
there.
get recommended? You have to be most often friends with the persons who have the power to give
Hmm.
their permission for you to go to these schools.
Yes.
So the 5 year is just the minimum requirement. But
Hmm.
bridging that gap from meeting the 5 year mark to actually being approved to go, it's a struggle. It is a struggle. It there's nothing easy about it. So it's like some persons avoid that route entirely because they can't be bothered with all
Yeah.
they have to go through in order to just start. And when you start, you have to think in terms of money too. A lot of things come down to money and the
Hmm.
competition that it's going to create locally with between doctors, nurse practitioners, even in the local area. I'm sure a provider would a doctor would prefer to have their practice, even if it's in the hills of somewhere, than for the expansion of the offerings of nurse practitioners. And if she or he has their practice in that particular area, then that whole area is no longer able to support your business. So
Hmm.
some things, even though it feels really cruel to compare like that, some things
Yeah.
come down to money.
Yeah. But persons need to start looking at the benefit of the greater good, it's to benefit the people. benefit the patients, more accessibility to care. That's what people do look at. But most persons are focused on money, but you need to look on improving the care or the health care of a population, which I think is very important. You need your
Mhm.
people for labor, for productivity. So they need to be having access to proper health care so that they can work and provide productivity for the country. No,
Absolutely.
another resources that we talked about, I want to piggyback off of this. I saw recently where Jamaica had a task force for AI. And I
You
saw the
don't
article and
say.
I was like,
I need to do some reading. Okay. I like
I'm
it.
like,
That's my alley. Anything tech related, that's my alley. I love
I'm
that
like,
conversation.
AI in
Hmm.
Jamaica. And I think before, when I saw the article, I was flabbergasted because do we have the technology to support AI in Jamaica at the moment?
We do.
And
We don't have it. We don't have the technology. We have the technology,
mm-hmm,
thinking computers, phones, that kind of thing.
mm-hmm,
But to integrate AI into practice locally, it's going to be difficult. To some extent, a lot of integration can be done, but it's going to be through particular individuals. For example, the providers. It's so difficult to get computers in some facilities, like functional working computers with internet access all the time.
mm-hmm.
Not just one computer, but just access so the providers can use the computers to assist with patient care, basically, documentation and all of that. But if they have that, that's a huge start because of how technology is right now. It's not as cumbersome as it used to be before. It takes less things to make other things happen. So I think we have the mind, the brilliant people in Jamaica, so many brilliant persons who would be excited, who would jump at the opportunity for, the whole integration of AI into patient care. But the huge thing with AI is privacy.
Yes.
How are we going to store patient information? How do we know that this patient information is
Hold
going
on,
to be,
hold on.
data breaches and all of that?
Let's just stick a pin right there before we jump into that other one, privacy. Before we go there, I honestly don't think, I beg to differ that I don't think Jamaica is ready. We have the minds, but we are not there, especially when you're looking at AI with healthcare. In the US, it's a big thing right now because
Mhm.
they are already there with healthcare. When you're at work, you're using mobile phones, communicating with the doctors, you're using computers. Patients now have access to their own. That's something that we need to talk about. So patients have access through their mobile phones to their charts.
Mhm.
Many hospitals, clinics are using the mobile access. They have tablets being walking out, nurses using tablets, doctors. Where do we see that? Probably I left the system. I don't know what is it now, but where do we have that capacity? We don't even have a lot of complaint is that we don't have CT machine in Jamaica. I don't see where we have the capacity for that right now. My thing is that we need to have a task force that advocates the government for adequate resources and technology. Then we infuse AI. It's good to have a talk about it and what it can do to transform the system. But how many persons have access to internet? Mama, we live in Portland and some rural communities. Do these people even understand how to use those devices also? I know it's
All
a
right.
big thing
So
here.
for me, they can improve both things in terms of the equipment and access to the information and AI. They can do it hand in hand. The more expensive side of it
Mhm.
is getting those equipment and not just getting them, keeping them working. That's
Maintenance.
gonna be an issue. The area I think that's easy to implement is like for physicians who would use like these protocols. For example, this is what works for diabetes. This is what works for DKA. You don't have to remember what you learned in medical school.
Mhm.
This is something that works. You pull from a pool of information or have protocols for how things work and use AI to help to solve that issue. So that would call for less resources. For example, a computer with access to certain software in the physician's office, even within the public healthcare environment. If you have that available, that's a huge step. The
Yes.
patients may not have access, it's like a phased basis. The patient will not have access to their medical information online initially because who's going to store that? Who's going to protect that? But at least the providers allow the patients to have a better chance of a more positive outcome because the information that they provide is more consistent. How I treat diabetes in Kingston is the same way I treat it in Portland, in the rural community in Portland, because if the metrics add up, if your blood glucose is this level and we meet all these other parameters, this is what is done in a
Mhm.
first world country. Because some things we can do, but the expectation is not that we're going to have like access to all this information and people are going to be able to, look up some things online. But I will challenge um, private offices. If you can do that, that's a huge win for you. You can
Yeah.
allow your patients. There's so many really, really good tech people in Jamaica, companies who can build you that website that will allow you to store your patient's information. So if as a private practice you can do that, it will it will add another level of not just confidence from your patients, but people want to know what's happening,
Right.
and it's like, wow, when I go to Dr. So and so office, I get my results when they are done, and I don't have to come back to his office in 2 days to get the results that are published later today. So greater access to information is what's happening globally. And if we can start that on a phase basis, it may not be face to face down with the patients, but if we can incorporate that in practice, even just with the providers, I haven't even reached the nurses yet, but just with the providers,
I
certain software, for example,
yeah,
Lexicomp, that allows you to, check your drug interactions. I remember when I was in nursing school, it was a drug guide,
drug guide.
that thick
They
book
have
that
those
was,
on the computers. Hmm.
yeah, why not make that available? Stop bashing the use of certain technology within the hospital space, because I have a Lexicom software on my computer. They're kind of more integrated now into a software called Up to Date. And
Hmm.
there's no shame. In the US, providers check Up to Date all the time.
Yeah.
There's no problem if you don't know something. You should just go on your device, go to a trusted source. All these things are peer reviewed journal articles. You just look for stuff, you find it, give the
Hmm.
patient accurate information. So, some things I would love for a group of practices to do that, just to get up to date app, get Lexicom, something, incorporate that in your practice and see how that goes. They can be the test subjects.
I like
Yeah,
Sherian, Sherian is super positive. It would call this positive, super
I
positive.
enjoy this topic. Anything related to tech, girl,
Tech.
I'm
I
with it.
love it too,
Yes.
but I have to be, for me, realistic. I don't know if you saw the video recently where a doctor flew back to Jamaica and he was offering to help and do surgeries, and the AC
Oh
in the
yeah.
operating theater wasn't working. So those are the simple things that we need to work on, because that for me is still technology. And I love how you mentioned that we need to have like lexicom, the computers, and it can be done. But we need to look at also, if we're going to infuse AI, where are we in terms of documentation? Because are we using those documentations on the computers to be infusing AI as yet? So for me, I honestly think that we always have this type of thinking when we are literally here, and it takes baby steps. I don't think
I
we're ready.
yes. Baby
Takes baby
steps.
steps and it can
Mhm.
be done, but we're not ready for it as yet. I think the entire system needs a complete overhaul, infusing technology to see the importance of it, or we can make it more efficient and effective. Then we can talk about AI. Another stone I like to throw in this wheel too is that task force that they have for AI is a nurse or a doctor on that task force, because these are the individuals that are direct impact in healthcare. Those persons should be on it submitting a proposal to say, hey, this is what needs to be done and this is how you should do it, because it makes no sense. It makes no sense.
And I think as nurses too, we need to make ourselves, well, put ourselves in a capacity that we can be advocates for certain things. For example, I like to read the outcomes of research, but I am
Mhm.
not going to be the nurse doing the research, that kind of thing. So we need to put ourselves also in a position that we can, write the proposals with the use of AI now. Thank you. Write the proposals, know who to bring these proposals to, and advocate for nursing in general. And I have one word for that incident that happened at Busmante Hospital. That's just disrespectful.
Yes.
Disrespectful. This gentleman is giving of his time for free. You know, flying himself to Jamaica. I'm sure he didn't come alone. He must have had a team with him
Yes, he did have a
because
team. He
he
said he
must
had
have
a
had a
team.
team with him, taking time off his regular practice. This man could have been on vacation. He could have been on vacation.
Better yet, he could have
It's
been on
crazy.
vacation doing telehealth, doing something virtual and talk and interacting with his patient, getting paid.
He could have gone to another country.
Hmm.
Would have had a working AC system. So it's
Yeah.
disrespectful. Honestly, disrespectful. It's like the shake my head kind of moment. I said, I'm like, really?
And that's the
Really?
state that we're in, and it begs, that this is where I always talk about that the system needs a complete overhaul, restructuring, revamping, because our people deserve the best, and that's what I
And
believe
that's
in.
that word I had that word in mind. If you don't think you deserve it, you're not gonna fight for it. It
Yeah.
works in every relationship. It works in a
Hmm.
marriage. It works as a nurse, whatever profession you are.
Hmm.
If our providers, our doctors work in that unit without the AC, why are they going to advocate to get it for somebody else? We work in it. I'm not saying they didn't, I'm not, but the authorities have been accustomed to them working under those conditions.
Hmm.
So it's like if you can work on it, you can bring somebody here to work under the same condition as well. If you don't think we deserve better, nobody's gonna fight for better
Hmm.
for us. We have to get to the point where we want to see it happen. We're willing to work towards, seeing it happen. It's not gonna be overnight. It's
Hmm.
gonna be little by little. But that's why it can't be one person's fight.
No.
Because if it's one person's fight, you're gonna get tired. You
Yeah.
have the rest of your life. So it has to be a collective, a group of persons working towards this one objective to improve healthcare, whether you're local, international, but working together and doing that, I think
Yeah.
can make a major impact.
One thing I saw recently that the US did, the first university, I think it was in Florida, they are now working on getting the first cohort for a master's in AI for nurses. And I thought that was super impressive.
I'm gonna search that as soon as we're done
I
here.
probably can send you the information. I think
Absolutely,
this is
thank you.
it's been spearheaded by this lady that I follow on LinkedIn called Rebecca Love, very big on innovation, and she's a nurse.
Mhm.
And she's spearheading that because they see the impact that AI will have on healthcare, and also the nurses are the ones that are going to be utilizing this, and they're now having a master's program for this. So these, you see how the preparedness is coming, so
Yes.
sometimes it begs the question like, where are we?
Listen, some facilities in Jamaica are just now getting computers for the nurses, for example, in the emergency room, to do basic documentation for the intake process.
Hmm.
It's a long way to go. We know it's a
Long.
long way to go. That's why I was saying the easy thing, an iPad, a tablet, if a physician has access to that, download this one app, these two apps that will help you,
Hmm.
in terms of knowing the information, because if you think of it, what's the point in knowing what to do and the patient doesn't have access to the necessary equipment that you need to get it done? It's like, okay, we're doing well on this hand, but it really doesn't make any sense because the patient's outcome is still negative because you don't have the resources. So that's why I think we could work, improve both things, slowly but surely in the right direction.
Yeah.
But the way the world is going, we need to catch it. Not
We
even
have
catch
to
up. We need to get going with something.
catch up, get going, running, everything. I like how you mentioned that, and this is something that I saw when I came here, that they utilize the computers, electronic systems, and many a times they have a system where they can use the system to tell how long a patient has been in waiting. And you can
Mhm,
look at the time, and that is very important. Like they can say,
mhm.
hey, the patient has been here, they're waiting for a bed. Very impressive with that, so that it doesn't take too long in delayed care. That goes back to technology again. One culture shock that I realized is that what shocked me when I came here is how patients have their access to charts.
Mhm.
Access to chart, they can tell you everything that is happening with them. Back home in Jamaica, you have the
You have to read that
dockets,
docket.
and you
Yep.
just hug it up.
Mhm.
Not accessible to patients nor their family members.
Sometimes it's not even accessible to you.
As
Haven't
the
you ever been
nurse,
on the floor where you want to document something, but the doctor is doing the rounds and you don't have access to the patient's
no.
chart to write in it?
Hmm.
See, no, that
what
sounds
is your
crazy.
stance on that? Do you believe that patients should have access to their charts, and also, if their significant family members were like over them taking care of them? Do you believe that that's something back home could help to improve the system?
What access with the physical charts? Because that's
Yes,
what we use for the most part. The physical chart is what we use.
I know for them, for some hospitals, they have access to some in terms of their lab values, the
Absolutely,
plan what the doctor
absolutely,
is doing. So that's what I
yes.
was asking.
Absolutely. But we have to know how are we going to share it? It goes
Mm-hmm.
back to security. How are we going to share it? Because if even at this point, when I go to my primary care doctor, lab values, even though they're negative, certain lab values they're sent on it on their portal. They don't
Mm-hmm.
email it to you through Google, through Yahoo. People still use Yahoo. I don't know, through Google or Yahoo or
Me use
whatever it
Yahoo,
is.
miss. I use
Oh
it.
my goodness, you do?
I was, I got hits in the face. I have Gmail still. I do have
Oh,
Gmail.
okay. So that's okay. But you can't depend on these third party
Mm,
apps to protect your, confidential medical information. So we need to find a structure, some place that's gonna keep the data safe, that's
mm.
trusted and proven. I don't necessarily want this to be innovated in Jamaica, brilliant as we are, but something that's already proven that other well-established healthcare systems are already using to allow persons to access their information. But I'm all for access.
Yes, I do believe that it helps too, because it keeps them informed of what's happening, and it allows them to
Mhm.
have more advocacy and to be aware and more communication. So I think that's something, that can help to improve the system. Another thing that I wanted to ask too, in terms of privacy. I know we talk about the technology, and this is where I said we're not ready. When you look
Mhm.
at so many errors that we're having back home with scams, all of that, people accessing financial information, with
Yep.
AI and healthcare information, privacy, access to data is going to be a big thing too. So that's something that the system has to look at.
And that's not unique to Jamaica. It's just
Hmm.
that we see, and listen, I've never experienced attempts to scam
Hmm.
like I have since I've been here. Since I got my phone number, I've been getting calls. So it's not like we're in a better place and
Right.
we don't experience these things anymore. They absolutely do exist. But
Hmm.
Jamaica is such a small is a smaller population. Um, you don't want the information floating around out there. You're the only John Brown in your whole community. There may be 10,000 John Browns in your not your state, but in your zip code here. So it's different when that information is leaked, private, sensitive information. We're not able to keep people's financial information confidential. It's going to be really rough if we can't keep medical information. So we have some ways to go
Yes.
before we, integrate that. But I'm saying smaller facilities, smaller private facilities, or doc providers' offices can take this on as something that they want to do for their patient group. And I know that they're willing to spend the money because it's not coming out of their pockets technically. You're gonna charge the patients. Patient visits are gonna cover this. But if you can do that, I know that they're gonna see some positive results from it.
Yes. One question based on this discussion that we're having, it begs to ask the question: do we have quality healthcare or access to quality healthcare in Jamaica?
Quality is very relative. I would say we have access to healthcare. Quality is just to the extent that the resources are available to care for you, really. So I just say we have access to healthcare because I keep going back to this. If you come to the emergency room with signs of stroke, your hospital does not have a CT machine. You're either gonna I've made so many trips. I felt like the ambulance nurse sometimes. So many trips from the emergency room to KPH and UE or Andrews Memorial Hospital. So many trips. If you don't have the money to do the test, that's the first thing. You're gonna have this brain bleed and you're gonna watch it deteriorate. If there's an occlusion and you have some deficits in whatever side of your body, they will continue. If you don't have money to do the scan, you don't have a chance. What are we gonna do? We can't do anything for you. So we have access to we have access to healthcare, but the quality is very debatable depending on how much money you have access to, where you're located. Because if you're located in a very rural area, you're gonna be home with your stroke signs for until the next day when you have transportation to take you to the hospital. So there's access, but it's like, can you access it?
Yes,
It's
can you
available,
afford
but
it
can
too?
you utilize it to a
Mm-hmm.
certain extent? You go to the doctor, okay, you're not having a life changing or a life altering event. You get a prescription. You go to a hospital pharmacy because you don't really have a lot of money. They're out of the medication. What do you have? You have a diagnosis, but how is the diagnosis helpful if you're not able to actively treat what's happening to you? So it's tough. It's
Yeah.
really tough, but it's a work in progress, I guess.
Yeah, I there's access to care, and I think, we do good work back home, but the level needs a lot of improvement,
Hmm.
super improvement. When you talk about quality standards, I think it needs a lot of improvement, and especially when you talk about the gap in terms of those who have access to care with rural and urban persons living in the
Hmm.
urban areas, Kingston metropolitan, compared to those living in the country areas. And then by the time they get admitted to those hospitals, the wait times, the lack of an ambulance to take you into the urban area or even a helicopter. Those
Oh,
are,
I've had experienced that twice. I didn't
yes,
get to enjoy the experience
Mm-hmm.
because it was like my patient was near death, dying,
Mm-hmm.
kind of.
Yeah.
Yeah, but it's hard. Many times I've been in the emergency room and the patient is for a CT scan. They don't have the money. They make a call to foreign,
Mm-hmm.
and the relative say, I'm going to send the money to Western Union tomorrow morning, first thing. So you come in at 8 p.m., whatever is happening continues to happen
Mm-hmm.
until tomorrow at midday, because when the money comes at 8 p.m., the relative is gonna join that line at Western Union.
Yeah.
They're gonna get the money. Sometimes you have to go ahead of you and book the appointment
Mm-hmm.
at the facility, and then you get transported. So it's like this is almost 24 hours later, and
Yeah.
we're not really sure what's happened to you, but it looks like this, so we start to
Mm-hmm.
treat you, like that. So the treatment is kind of a catch-all. Sometimes it's not very specific. But I tell you, as in, case of everywhere else, if you have a little bit more access to money, it
Mm-hmm.
does help with the quality of care that you receive. Not because people treat you differently, but you need money to access these services that's gonna be used to make the determination of how you'll be cared for. It's sad, but it's a reality.
It's a reality.
Mm-hmm.
One thing I like with here, you do have access to the care, but you do have the gap in rural, urban, but the other
Mm-hmm.
services are there and they're quick. Everything is accessible, but you're gonna get that bill once you're
Oh
finished.
yeah, for
Yes.
sure.
Yes.
And just to compare that, I had a patient once. It was the first time I really thought about deeply about some things here. He kind of came up with several reasons of why he couldn't do the CT scan.
Mm-hmm.
It was a CT scan. It's a CT scan of the head and the chest. He said he didn't have the money to do it. And it's like for me, this is when I just started in emergency. It was like, sir, the CT machine is like 2 minutes away from the emergency. What do you mean you don't want to do the scan? But this gentleman was like, I don't have it. Like they were willing to do it. Money was not an issue with doing it right now, but he's thinking of the repercussions. If I do this scan and the bill comes in the mail, it's gonna be my bill, you
Yeah.
know? And he talked himself out of it. It was such a sad experience. Um, so even though he had access to care, he was so scared to utilize the access he had because he was concerned about the financial responsibility, and that's a thing that exists everywhere.
Yeah. I like when we were talking earlier, as we almost closing, if you have any more any other thought of to think of. I like when you mentioned stroke when the patient came in and that rang a light bulb in me that, that's one of the most common conditions that you see back home. And how many of our hospitals, I know it's far fetched, when you come here, you have stroke certified hospitals, you have a
Mm-hmm.
stroke code that, you have to alert, you have a
Parameters.
parameters, you have
Mm-hmm.
teams, that come in, and you have that the parameters. If the person comes in a certain time, this is what they have to get. So that
Mm-hmm.
access to care and those goes back to quality, and those goes back to the standard of nursing globally. What we're doing works well, as we talked about earlier, when you're in the system, but when you transition out and you see what the world is doing, it begs the question, when will we reach there? And
It's gonna be
how?
a long and winding road. But I feel like a part of my experience, I really appreciate how we introduced this whole topic.
Mm-hmm.
Like, why are you interested in all of this? Jamaica is still home. It's gonna be home.
Yes.
Even if I live in the US for 25 years, it's gonna be home at that point. It's home right now,
Can I say
right?
something?
Go
Just hold
ahead.
the thought. And when you travel back
Absolutely.
home on a plane, and if anything happens to you, your
Yes.
care is going to be there.
Hmm. And can you imagine the nurse on the receiving end? Like, I'm waiting for an IV, and you're like, I have to wait for the doctor to set the IV. It's gonna be like, oh my gosh, really? I'm back at this. I could just do it
Mhm.
myself if I could. I can't even I can't even stick myself for a glucose check. But that's where my brain is gonna go. Like, are we
Mhm.
really doing this right now? And
Yeah.
it's a frustration. For example, people who travel abroad, they have that issue when they come back to Jamaica. Say, oh, you can't do this, and you can't do that, and you can't do that, and they'll tell you, oh, in the US I do this, I do that, and I do that. That's for another discussion. Anyway, but I think that so much can be done, so much can be done, and there's no point in us trying not to embrace AI. It's not going back. It's here to stay. It's
Mhm.
gonna go forward. But before we get there, we need to. There are a lot of things that we need to tidy up before we get to delving deep into AI. But the discussions, the floor is open for discussion. And
Mhm.
as I was saying before, I think a part of my greater value of being here is to be able to share what I've learned. So I really appreciate this, this platform where we can have a discussion, open discussion about, you know, just comparing the two countries, but
Mhm.
just being able to moving it from a discussion to being able to actively advocate for certain changes to be made because my entire family is in Jamaica.
Yeah.
People in Jamaica deserve quality care. Tonight I could admit to quality care, I could admit to care
Yes.
just to a great extent. There are places that give superb care. It's not because the persons are not caring. We're
Mm.
very caring, but we don't have the resources to adequately provide for your need, when you need it. So, just to take the discussion from here to actually contributing intellectually, not
Yes.
financially,
I hope it
to a
doesn't
great
fall.
extent.
I hope it doesn't fall on deaf ears, and that persons actually listen. And I'm happy that you took the time out and that we can have the discussion to talk about it. No way, shape, or form we're bashing a system, but we're just
Mm-mm.
nurses who are passionate to see growth and development back home. And I always tell people, not because you see persons transition to another country means that they're finished, with their countries. There are other countries,
Mhm.
I always speak highly of like persons that like living in China. They always move to other countries and they are very advanced right now. It's from their people, going other places, coming back, sharing their ideas and their resources. I think we have so much in Jamaica that we can improve the system, but it just takes advocacy that you talk about, persons who are sitting at the decision table, be willing and open to change.
Mhm.
That's
Absolutely.
another that's another thing, because as we said mentioned before, sitting in something and doing it over and over, you may think it's a norm and think it's okay. It's until you step out and you get an experience in another place, you realize, whoa, we have a lot of work to do. As what you said, a lot of tidying up.
Yeah.
Very important. So I'm really, really happy for this discussion, and I hope it goes to other places. And just any nurses that are listening, out there, just helping to advance the system globally. That's what we're working for. Just a point I'd like to add. I saw this the Ghanaian, they call it the Ghanaian Association Nurses of Ghanaian diaspora of nurses, and I said that's really lovely. Where there are a group of nurses and they push research and development, and they all come together and help to advance the state of healthcare and nursing back in Ghana. And that is
No,
something
that's
that
nice.
I was so impressed with it, and I was like, what do we have for Jamaicans? You know, we're super talented. Many of us are dominating our spaces, climb the ladder,
Hmm.
career ladder, and I think we need to come together, to push, research and to help to advance our country globally. And I think that's not one person work; that everybody has to
Has to
share
be a group of people. Hmm.
that same perspective, and we can help to advance nursing globally. Still love our country, very
Absolutely.
passionate, very passionate
Absolutely.
and patriotic, even though we're not living there. But we are looking, still hopeful and optimistic that Jamaica can, in terms of healthcare, can improve and will improve. One last question I'd like to add. I know that you did international nursing already. I love to ask this question because everybody's answer is always different, very important and powerful. Is that what advice would you give to any nurse that is out there waiting to transition and wanting to work in another country? The fears that they're having and wondering if how they manage. What advice would you give to them?
You can do it. If I did it, you can do it. I had no reservations in terms of like fears in terms of nursing, but just moving to you move to a whole different country, different culture. It gets worse when you have a family. So you're not the only one transitioning. It's your whole family. Each family member is transitioning with you as well. But be positive in your outlook. Forget what people said about other people. For example, in Jamaica, there's a lot that we can say about persons who are discriminated against because of their ethnic background. You know, the browning versus the dark skinned girl. In America, it's like blacks versus whites. Experience it for yourself. I've heard some really terrible stories about how persons perceive. Sometimes it's just a perception that you're not
Yeah.
being treated well.
Hmm.
Sometimes it's actually you not being treated well. But come into it with an open mind, be yourself. Of course, you have to adapt to the culture and how persons interact. It's different. People are more open. People speak more about themselves. They're going to ask you about yourself, your family, your pets, your
21
wallpaper,
questions.
whatever. It's different in Jamaica. So you have to be open, be patient with yourself. It's going to take you some time to adjust and adapt. Always be willing to learn. You're like a sponge when you come. Learn from everybody. You're not a patient care tech, but you see them doing something. Learn the technique of how they do get that done. You might have a patient care tech every day, so you're gonna
Hmm.
need to know how to do things. Be open to learning and not just be open by yourself. Voice. Let people know
Yeah.
that hey, if you're gonna do this, I'd like to see it. I like to know how this is done. And listen, I have no embarrassment about asking questions. I think I used it more when I just came. I'm like, listen, I just came to the US. I've never done this before. Can you show me how to do it? It took me some time of practicing in my mind how to, because that requires a certain level of humility and knowing that despite my 10 years of experience in Jamaica, that is not relevant right now because this is what we need to be done and I don't know how to do it. So you have to just put yourself back in the frame of mind that, hey, I was awesome in Jamaica. I was the lead of my department. I was a go to person, but now I'm the person that needs to go to somebody. It takes a certain level of humility. So be willing to start over, be positive, and don't shut out the persons who are on your side. If you have immediate family, like your husband, your wife, whatever it is, allow them to help you along the way. Don't be anxious by yourself. It's tough out there. Share how you're feeling. Work was difficult today. If you need to cry, cry. And get that support from your family. And just know that you can do it. Be positive. I've told people if I can drive, you you can do it too. If I can drive on the streets here, I was terrified. It took me 2.5 years before I was
Oh,
driving by myself.
no, Sherry.
You see what I'm talking about? It proves my point. So if I can do it, if I can do it, just be open to all other things. You can do it too. And of course, you're gonna learn on your own. YouTube, excellent resource. And in closing, that is what inspired me to start my YouTube channel when I did because, I had questions and there weren't many answers out there. I had
Yeah.
to be searching the web real deep to find answers to some things. So I initially created that space to answer simple questions. I didn't even do anything super deep. It was just simple questions of how to, the initial steps. So if you have other nurses who have been there, done that, talk to them if you can, watch their content if you can, ask questions in the comments if you can, follow them on social media because you want the information, they have the information. Ask questions. Don't listen to one person either. Listen to different people's perspective because our experiences may be very different, but it's a way of getting you informed so you can navigate the process better. So I know that's a lot of things,
No,
but
you're fine.
rewatch the video if you need to, so that you can, pick what works for you and just do that.
Yes, and I always say to people that the grass is greener on the other side. I heard it from someone else, and it has always stuck with me. The grass is greener on the other side until you see it for yourself. And you know,
Perspectives.
yes. So I am very grateful for having Sherry and Nurse like me coming on this platform. Speaking and talking about healthcare in Jamaica, raising the standard of nursing globally because we're still passionate and we want to see our country succeeding. Highly. And Sherry can be found on social media, as we said before, on Instagram and on YouTube, where she does content for international nurses also. And we
But let
hope,
me say, on Instagram, I had a page that was compromised. So you'll
oh,
see my face on a page, a nurse like me. That's not the one I'm using now. It's a nurse like me underscore.
a nurse like me understand. Okay.
Mm-hmm.
I think I can pin it in the comment section too. A nurse
Yeah,
like
that would be
me
cool
underscore and also
for
pin
Instagram.
your YouTube page so you can send me that also. So if you're watching this and you like the video, guys, send it to the persons that would need to hear this and so that we can create change for our home country, Jamaica. And we're super proud
Absolutely.
of Sherry and her achievements. We're all over the world, Jamaicans doing well. Even if you're not from Jamaica, watching from the Caribbean, you can succeed too and you'll do exceptionally well. So thank you guys for watching our video and stay tuned for more.
Thank you for having me.